It's actually not a bad day here today in Wisconsin. A little chillier than it's been, but sunny, so that's great. And thank you for coming. And to introduce you, we have Dr. Christy Bartels, our Division Chief of Rheumatology. Christy?
Thanks so much. It is my great honor to introduce Dr. Marcy Bolster, the professor of rheumatology at Harvard Medical School and director of the fellowship program in rheumatology, allergy, and immunology at the Massachusetts General Hospital. Dr. Bolster received her medical degree from Duke, followed by internal medicine at East Virginia Graduate School of Medicine, and her rheumatology fellowship at Medical University of South Carolina. She has devoted her career to training rheumatology fellows, internal medicine residents, and medical students. She's been the recipient of the ACR's Distinguished Program Director Award and the Massachusetts General Brigham Outstanding Program Director Honor. She's had leadership roles, including the ABIM Rheumatology Exam Committee and being a member of the ACGME Milestones Working Group. She's a member of many education committees at Mass General, and she's had teaching roles, extensive teaching roles at the Harvard Medical School. She's led many efforts also through the American College of Rheumatology, including the 2015 workforce study, the interstitial lung disease guidelines that we just said. Our own Dr. Christine Sharkey was on the voting panel for that, and she's been on the ultrasound task force again as well. She's currently a member of the Rheumatology Research Foundation Awards Audit Committee. As the PI of the Rheumatology Research Foundation's Clinical Scholar Educator Grant, extending our reach, she also developed an educational curriculum for rheumatology fellows to deliver synchronous and asynchronous care to underserved communities. This program was piloted at Mass General and the Rosebud Indian Reservation in South Dakota with the intention of disseminating to other fellowship programs. Dr. Bolster's interests include rheumatoid arthritis, scleroderma, and osteoporosis, and she has been the medical lead for the Massachusetts General Fracture Liaison Service. It's really difficult to mention all of her notable accomplishments here, but please join me in celebrating Dr. Bolster, that in addition to her many contributions to training the future generation of educators and rheumatologists, she will share with us her expertise this morning in her discussion of osteoporosis and antiresorptive therapy for commonly asked questions by our patients. Thank you and welcome, Dr. Bolster.
Thank you, Dr. Bartels, for that very kind introduction. And it's really such a pleasure to be able to join you here today. Thank you also to Dr. Schnapp for inviting me and to Dr. Kevin McCown for his contribution to my invitation. And I look forward to the session with you and would certainly welcome your questions. My approach has been to try to create a presentation that is very applicable to what our primary care providers and colleagues would be facing in the realm of osteoporosis, and also many questions that come up in the subspecialty clinic. Here are the disclosures for those involved in the grand rounds today. None of these for me are particularly relevant. And I thought I would provide you with 4 questions that we will use for the discussion today. The 4 questions that I chose do relate to antiresorptive therapies, but I actually kind of broadened that to be a little beyond antiresorptive therapy as well. So the first question we'll address is, do I need to take calcium and vitamin D tablets? Another question patients ask is, what should I expect regarding side effects from the medication you are recommending? When I start this medication, how long will I need to take it? And do I need to change my medication since I had a new fracture? We'll start with the first question. Do I need to take calcium and vitamin D tablets? And I will say that calcium and vitamin D tablets have been, I call it kind of an accessory to the mainstay of therapies. All of the clinical trials for our medications to treat osteoporosis have included the fact that patients are taking calcium and vitamin D supplementation. But you'll remember that maybe 10 or 15 years ago, there became a quandary about calcium and cardiovascular disease. And although there were many studies that helped to reassure people that calcium was not associated with an increased risk of cardiovascular disease, there still remains a question. And our patients frequently ask, do I need to take calcium and vitamin D? So I will address both of those. And I'm going to take you maybe on a walk through history, looking back at 10 to 15 years ago at what came up in terms of calcium and cardiovascular disease and that controversy. So I'm going to present a little bit of data. I'll start with a large meta-analysis that was published about 15 years ago. And this was looking at postmenopausal women in randomized trials. They looked at trials that included a calcium supplementation of 500 milligrams daily or more. They required that the trials have more than 100 patients and that the mean age be over 40 years for the patients. And the trial duration also had to be longer than a year. And the conclusion from this meta-analysis was actually that calcium supplements were associated with an increase in risk for cardiovascular events. However, when adjudicated for MI versus self-report, there actually was no significant difference. There was an Australian prospective randomized study of calcium supplementation. I'm going to draw your attention also to the dose. So that the meta-analysis was 500 milligrams or more. This study looked at 1,200 milligrams daily. It was not nearly as large, but it was almost 1,500 women. And it was a 5-year study with 4.5 years of follow-up. So a substantial time of follow-up. And it did find that calcium supplementation was associated with a reduced rate of hospitalization and reduced mortality in those with atherosclerotic disease. Another study, which was the NIH AARP study, looked at diet and supplements. This was a prospective study with a mean follow-up of 12 years. There were almost 400,000 patients aged 50 to 71. So this is kind of the population of patients we would be seeing for bone health. And this study evaluated calcium intake by diet and supplements. Vitamin D, however, was not assessed, and that's okay. And this looked at calcium supplementation of over 1,500 milligrams daily. So again, the dose I want to draw your attention to. And first of all, this found that for men in the study, just over half took supplements. And the men were demonstrated to have an increase in cardiovascular disease deaths, but not deaths by stroke. For women in the study, 70% took supplements. And again, the supplement dose was over 1,500 milligrams daily. And for women, there was no association with increased cardiovascular disease or stroke-related deaths. So in this study, calcium supplementation was not associated with increased cardiovascular disease or stroke-related events or deaths for women. However, for men taking calcium over 1,500 milligrams daily, there was an increase in cardiovascular disease-associated deaths. And I'm a visual person, so I thought I would share with you one of the figures, but I realized that it's very hard to see the actual numbers. I'm highlighting where the curve crosses 1 for men, and this is at a dose of 1,500 milligrams daily. So at lower doses, there was not an increase association with cardiovascular disease or stroke-related events. And for women, there was not. The calcium controversy is continuing, and there was a Swedish mammography study, and this was over 60,000 women who are followed now for a median of 19 years, so quite a long time. And this showed that in these women taking over 1,400 milligrams daily of calcium, there were higher death rates from cardiovascular disease. And this related, they looked at all-cause cardiovascular disease and ischemic heart disease. And they found that although for women taking over 1,400 milligrams daily, there were higher death rates. Those taking 600 to 1,400 milligrams daily did not show an increase in mortality or cardiovascular disease-related deaths. So increase in overall mortality or mortality related to cardiovascular disease. So in summary, from this study, calcium doses in the range of 600 to 1,400 milligrams daily did not show increased mortality in all-cause mortality or cardiovascular disease mortality. And now I'm going to comment on the Women's Health Initiative, which was initially a 7-year follow-up study. And so patients were treated, were studied for 7 years while on supplementation with calcium and vitamin D. And the Women's Health Initiative did not show a difference in MI or stroke. But this is kind of new news because there was a publication just this month looking at a post hoc analysis for the Women's Health Initiative. And this is 22.3 years of follow-up. And this study showed a 6% increase in cardiovascular disease mortality. So the women were taking calcium and vitamin D for 7 years, and then the post hoc analysis looks at 22 years of follow-up, though there's no data on what was happening with calcium supplementation for those women for the years between 7 and 22.3. Interestingly, the patients who had 7 years of calcium and vitamin D then looked at post hoc 22.3 years of follow-up, showed a 7% decrease in cancer mortality, though there was no change in cancer incidence. And this was similar to the 7-year study. So whereas the 7-year study showed no difference in MI or stroke, there was an increase in mortality-related cardiovascular disease at the 22-year follow-up. And I think this was just published. And so I do think that questions are going to bubble to the top again about patients wondering about whether they should take calcium and vitamin D, because they may hear that, oh, calcium was associated with increased heart disease-related mortality. And this plot shows you, I'll highlight again, because I know that it's hard to see the words, but this is showing the cardiovascular disease-related mortality related to calcium intake being increased. And this is showing a decrease in the cancer-related mortality. And there was really no difference, as I said, between cancer incidence. So I think there are some strengths to this study, but I think there's some important weaknesses or limitations. And one is that there's a long follow-up after a 7-year intervention. So it's really hard to know what happened in terms of the role calcium played in these outcomes when there was a 7-year intervention and a 22-year follow-up. The other important limitation of this study, in my opinion, is that there are multiple comparisons made. And so some of the observations could be occurring just by chance due to the multiple comparisons. So I do think that this doesn't necessarily change our thinking in terms of, it doesn't change my thinking in terms of the role of calcium and vitamin D in terms of importance for supplementation and managing patients for their bone health. And you can see that these major stakeholders in our understanding of bone health. So the Bone Health and Osteoporosis Foundation was formerly the National Osteoporosis Foundation, International Osteoporosis Foundation, the American Association of Clinical Endocrinologists, and the Institute of Medicine all recommend that calcium intake should occur predominantly actually by dietary sources plus supplements. And the doses are the total daily intake is listed. And what I do is I talk to my patients about how it's important to have adequate calcium intake, and this should include dietary sources, multivitamins, and calcium supplementation. And I really don't have any patients who are on more than 1,400 milligrams of calcium a day by supplement. And that's where all those other studies really ran into problems in terms of, or demonstrated increased risk of cardiovascular disease. And that was with the higher supplement doses. Here's just a kind of suggestion that I provide to patients. If patients enjoy dairy, then milk and yogurt can be good sources. Almond milk is actually a great source of calcium intake through diet. And so I generally tell people that if they can have 2 servings of calcium containing foods, that gives them about half of what they need, and then they can take 1 supplement. And here's an example of looking at the back panel, which I think is important for patients to see how much calcium is contained in their supplement that they're taking, and to also make note of how many tablets is a serving size, because some of the supplements will say that it's 600 milligrams of calcium, but it's 2 or 3 tablets per serving size. And then how much vitamin D. So we'll talk for a moment about vitamin D supplementation and intake. And I think the healthiest way to get vitamin D might be with some sunshine, which I hear in Wisconsin, there is actually some sunshine today. And of course, we have to counter the sunshine with the use of photo protection or sunscreens, and that does mitigate against full vitamin D formation. But what is recommended for vitamin D supplementation is 800 to 1,000 international units daily. This is a little bit harder to get from food sources, and there are some patients who require or who would warrant higher doses if they have vitamin D insufficiency. The best way to get vitamin D, honestly, is going to be with supplements, just because it's hard to get a lot of it through diet. But we also have studies that raise the question to our patients, and they are coming in saying, I heard it isn't important for me to take vitamin D supplements. And so I would like to maybe present for some data on this. And there was a recent publication in the New England Journal of Medicine looking at supplemental vitamin D and incident fractures in midlife and older adults. And this publication stemmed from a different study that was designed to look at cancer and cardiovascular disease. But there was an important publication that came out that really raised the question to a lot of patients and providers about the use of supplemental vitamin D because of the interest in preventing fractures. And so this was part of the VITAL study, which was vitamin D and omega-3 trial. And it was designed as a 2x2 factorial design, randomized controlled trial. And it looked at 2,000 international units of vitamin D daily, or omega-3 fatty acids, 1 gram daily, or both. And again, was designed to look for cancer and cardiovascular disease in men over age 50 and women over age 55. And the subject recruitment for this trial did not relate to those with vitamin D insufficiency, those with low bone mass, or those with osteoporosis. However, in this ancillary study, the primary endpoint was identified to be incident total non-vertebral and hip fractures. So total fractures, non-vertebral fractures, and hip fractures. And this study included almost 26,000 participants, 50% of whom were women. And we know for bone health studies, often the percent women is much higher than that. In this study, there were 1,991 incident fractures that occurred in 1,551 subjects. And the median follow-up was 5.3 years. And the findings were that in those taking vitamin D versus placebo, there was no difference in total fractures and non-vertebral fractures or hip fractures. So it showed that taking vitamin D supplementation did not reduce the risk of fracture. Hence, our patients come in and they say, I heard it isn't so important to take vitamin D. It doesn't prevent fractures. But remember, these were healthy people who were taking vitamin D supplements, and actually very few people in the study had osteopenia or osteoporosis. So I think many of us believe that we're really unable to draw conclusions about fracture prevention in patients with osteoporosis who are taking vitamin D. And in fact, there are many studies in patients who have osteoporosis, and vitamin D is part of the treatment regimen for fracture risk prevention. So for me and from many colleagues, patients who have osteopenia and osteoporosis, really the treatment recommendation continues to include calcium and vitamin D. I'll certainly welcome your comments and questions perhaps at the end, and we'll move on now to our second question, which is, what should I expect regarding side effects from the medication you are recommending? Because when patients come in and we talk about treatment, their first question is, but tell me about the side effects, really before I can even finish telling them about why I think it might be a good medication for them. And so first we're going to start with, honestly, who should be treated? I mean, just to make sure we're all on the same page, the decision to treat, as we know, is DEXA scan showing osteoporosis, which is a T-score of -2.5 or lower. or those who have osteopenia and an elevated FRAX score. But one of the really important parts of this presentation and how I think about patient care in terms of bone health is that patients who've had a hip or vertebral fragility fracture have osteoporosis by definition. And honestly, you don't even need a DEXA scan to decide for those patients that they want treatment. I get a DEXA scan because it would be like deciding to treat somebody's blood pressure without monitoring their blood pressure and seeing where they're starting. So I think it is helpful to have a DEXA scan for monitoring therapy, but for patients who've had a hip or vertebral fragility fracture, it's really essential that they get treatment. And then here are the treatment options. And I think about it, you could think about it in a number of different categories, but for everybody, they should be involved with weight-bearing exercise, which just means exercise on their feet so that they're weight-bearing. I address fall prevention, and as we've already discussed, calcium and vitamin D supplementation. And then you can think about the medications as daily, weekly, monthly, quarterly, twice yearly, yearly. You could think about them as oral, IV, subcutaneous. You could think about them as antiresorptive or anabolic. I mean, there are a lot of different kind of ways to categorize them. One thing I will bring up is that romosozumab does have a black box warning, and that relates to increased cardiovascular disease and stroke events. And so for patients who have had an MI or a stroke in the past year, this medication is advised against use. And we'll talk a little bit about the common side effects for the medications, because remember, the patient says, what are the side effects? But they also mean, what are the potential adverse effects? And so we will also address that. For oral bisphosphonates, the most common side effects would relate to gastroesophageal reflux, esophageal discomfort, chest pain, and for zoledronic acid, the most common would be an infusion reaction, which can occur in up to 50% of people with their first infusion. And we're going to focus mostly on the bisphosphonates because I feel like those are the medications that this audience would most commonly be prescribing and recommending. But I also want to mention to you, because patients may ask you about the other options for medications. And so the anabolic medications are also listed, the PTH analogs, as well as romosozumab, which is anabolic and anti-resorptive. And then denosumab actually has important considerations, and more on this later. You may see a patient in whom you decide to start an oral bisphosphonate, and I think you're well familiar with the GI side effects that can be experienced by patients. But you may also decide with a patient that they're not a candidate for an oral bisphosphonate and that you want to refer them for treatment with an IV bisphosphonate. So I thought I would talk more about the IV bisphosphonate zoledronic acid and the acute phase reaction. As I mentioned, it occurs in up to 30 to 50% of patients who receive their first dose. It's a flu-like reaction. I often describe to patients that it's similar to reactions that some people get to vaccines, such as the COVID vaccine or the shingles vaccine, and is characterized by joint and muscle pain, fever, occasionally GI symptoms. And I tell people that it starts within 1 to 3 days of the infusion. The data show that 90% of patients rate it as mild to moderate. And most patients actually don't opt out of their next infusion, even if they have this reaction. And I also reassure patients that it's not an allergic reaction. It's not an emergency. Patients don't need to be hospitalized. It's just a nuisance. And interestingly, about 2.5% report joint swelling. And here's a photo of a patient of mine who developed acute polyarthritis after receiving zoledronic acid. I think it was probably CPPD arthritis. She required high-dose prednisone, unfortunately, which is kind of counterintuitive to what I was really trying to accomplish with her. But this resolved with treatment with the prednisone. And we thought very carefully about whether she could or should get a dose a year later. And we decided to go ahead and have her get the dose a year later, and she did not have a similar reaction. And so she completed the course of therapy. You can see that the acute phase reaction is much more common in the first year and really tapers off after that. Can the acute phase reaction happen with oral bisphosphonates? It can. It's less severe and much less common. And if people have this reaction, it actually doesn't preclude the switch to IV zoledronic acid. They may get that reaction to IV zoledronic acid, but it shouldn't be more severe or more likely. The second part of this question regarding the acute phase reaction is, can it be prevented? And yes, there are data to show that there are ways to mitigate against this reaction. Acetaminophen, 650 milligrams or 1,000 milligrams taken 45 minutes to an hour before the infusion, and then 6 hours later, and even every 6 hours for up to 3 days, has been associated with an absolute risk reduction for fever or use of other medications to treat the symptoms. And so what I do is I recommend acetaminophen over NSAIDs, because NSAIDs, particularly in this population of patients, have more associated toxicities related to gastric mucosa and renal. So I think acetaminophen has been shown to be effective and is a good option. And scheduled dosing has been shown to be superior to single dose use for preventing the acute phase reaction. Now to shift from side effects to maybe adverse effects of the medications. And so thinking about medication-related osteonecrosis of the jaw, I'll discuss with you maybe a few facts. And again, we'll take a walk through history on this. First of all, just to make sure we're all on the same page, the definition of medication-related ONJ is exposed necrotic bone in the maxillofacial region. It's poorly healing for 8 weeks, and the patient has not had prior radiation therapy. The first report was linked to bisphosphonate use in 2003, and in this report, there were 36 patients who had been receiving IV bisphosphonates for cancer. And then a few years later, there was a publication by Wu and colleagues looking at 368 cases of ONJ. Most were treated with IV bisphosphonates, which included permethrinate and zoledronic acid. And most patients were receiving treatment for multiple myeloma or metastatic breast cancer. Some other patients had other malignancies, and only 4% had osteoporosis. And so further studies have looked at the incidence of medication-related osteonecrosis of the jaw, and the incidence is 1 in 10,000 to 1 in 100,000. And in the general population, this does occur at a rate of 1 in 100,000. So it probably is increased in patients on bisphosphonates, and that may relate to the form of bisphosphonate, the dosing of bisphosphonate, and other comorbidities, which we'll discuss. The highest risk is clearly with IV bisphosphonates, particularly higher dose IV bisphosphonates used for the treatment of malignancy. It's also been reported to occur in patients with oral bisphosphonates, denosumab, or romosozumab, with all three of these being antiresorptive agents. So the ONJ occurs when bone is exposed, so when patients are getting invasive dental procedures performed. And as mentioned, it's seen most commonly in those receiving IV treatment for cancer. But other forms, so the invasive dental work or dental trauma or even infection can be risk factors for developing ONJ. And we encourage good dental hygiene, of course, all the time. And also, we recommend that patients complete their dental work prior to starting treatment with bisphosphonates. The other comorbidities that have been associated with ONJ are diabetes, infections like dental infections, glucocorticoid use. And so I just advise to my patients that it's a very rare occurrence. And patients will also ask, well, what if I don't need anything now, but what if I need something before I finish my treatment course? And I just advise them that these things happen and that patients can get procedures performed, and just to let their dentist know that they are taking this medication, and they'll work very closely with them to provide oral rinses and really address the oral hygiene quite well. I borrowed this slide from a colleague, Dr. Zahidi, and I think this gives you a picture of the comparative risks for ONJ. And so any fragility fracture has a very high relative risk, and the hip fracture is lower, but still quite high. And then you can look at anaphylaxis from penicillin, death by car accident, death by murder, and then there's ONJ, which is just above death by lightning strike in New Mexico. So again, a very rare occurrence. And let's bring in the American Dental Association, because I will say I have spoken on the phone to more dentists in the past 10 to 15 years than I ever imagined I would be doing. And so according to the American Dental Association, ONJ is a serious and rare adverse effect for patients who are receiving treatment for osteoporosis. And again, higher dosage and more frequent administration, cancer-related indications are both associated with increased risk. And then also periodontitis or infection or inflammation, or even dentures, particularly poorly fitting dentures, can increase the risk. But the American Dental Association states that because of the high risk for fragility fractures, treatment for osteoporosis outweighs the potential low risk of medication-related ONJ in patients who need treatment. So I think this is also very important support for the benefits of our treatments outweighing the very slight risks. Well, let's switch to another adverse effect, and that's the atypical femoral fractures that can occur with antiresorptive therapy. And I explained to patients that this is a fragile bone problem that can happen in the thigh bone and result in what's called an atypical femur fracture. And for us to understand, it's a femur fracture in the proximal third of the femur shaft. It occurs in patients with osteoporosis, even those who have not been on bisphosphonates. And it may occur at an increased frequency in those patients who have osteoporosis and prolonged bisphosphonate use. It has been reported in patients on denosumab or who have taken romosozumab. Again, both of those have antiresorptive features. These can occur with minimal or no trauma. I've had actually 2 patients tell me that they were turning to reach for a dish towel in the kitchen and they heard it crack and then they fell. So the fracture occurred before the fall. Atypical femoral fractures are associated with delayed fracture healing. And importantly, about 50% are bilateral. So if you are suspecting an atypical femoral fracture, then you should obtain bilateral femur x-rays. And when I say if you are suspecting, the symptoms are honestly, they're kind of non-specific. Patients complain of or will report an achiness in their thigh or pain in their thigh or leg. They often are considered to maybe have trochanteric bursitis or radicular pain or osteoarthritis related pain. So I would just say if a patient is describing thigh pain who has been on bisphosphonates, then it's easy enough just to get bilateral femur x-rays, and that will help to offer reassurance. Here's an x-ray. It's a terrible appearance. This is a patient who had been on alendronate for 15 years, and her x-ray demonstrates the very key characteristics of an atypical femoral fracture, and that it's in the proximal third. It's not like a femoral neck fracture. There is cortical thickening. There is medial beaking, and it's a transverse fracture completely through the femur. So as I mentioned, these are most commonly associated with bisphosphonates. It's not yet said to be causal, but there's an association with long-term bisphosphonate use. As mentioned, this can occur in patients who have never even taken a medication for bisphosphonates, but who have osteoporosis. And it's also important that the risk decreases quickly after stopping the medication. So the study by Schilker and colleagues from 2011 was a Swedish study, and it showed a 70% decreased risk per year off the medication. And this rate has also been duplicated in subsequent studies. There was a more recent study that was published that looked at atypical femoral fractures and treatment with bisphosphonates, and the benefit of bisphosphonates maybe outweighing or countering the potential risk. And for every atypical femoral fracture that occurs, 1,200 fractures are prevented. And you can see the distribution being hip, non-vertebral, and vertebral fractures. Our patients really have a lot of concerns about the medication-related side effects and adverse effects. And importantly, I think it's helpful for us to walk through the potential benefits, which are tremendous, and the potential risks, which tend to be much lower. The other thing I do when I talk to patients about the potential benefits of treatment is I often ask people if they know anyone who's had a hip fracture or a spine fracture or a wrist fracture, but particularly hip and spine, because it's so difficult for people to regain their prior level of function after having one of these fragility fractures. And then when we think about the adverse events and we talk about the atypical femoral fractures, it really prompts us to think about the importance of a drug holiday. I particularly love this photo. This is actually unrelated to this talk, but I think an interesting anecdote. In January 2022, I was having a virtual visit with a patient. I was in Boston, and she was, I thought, going to be in Boston, and she showed me that she was actually in Aruba, which meant I couldn't have the visit with her because we didn't have out-of-state ability at that time in 2022. But I did ask her to show me where she was because I was in Boston and it didn't look anything like this. So it was really a beautiful moment. And it does also remind me about drug holidays. Which leads us to the third question. When I start this medication, how long will I need to take it? We're going to talk about bisphosphonates. And really, I think I've given you some information already about, are bisphosphonates good or are they bad? And I think when we talk about their benefits, hopefully we'll find that they are good and far outweigh their risks. Here's a case that any of us might see. A 68-year-old woman presents for a routine annual visit. She had a DEXA scan 2 to 3 years ago, and she thinks it showed a little bit of bone loss. She has no other health problems, and she takes calcium and vitamin D twice daily. Her mother had a hip fragility fracture, and the patient's height and weight are listed. She has a DEXA scan, and it shows osteopenia with FRAX scores of 20% for major osteoporotic fracture and 4.6% for hip fracture. And what would you recommend? Bisphosphonates are the first-line treatment. We've talked a lot about their risks. We have not spent a lot of time talking about their benefits, but we will talk a little bit more about that. And then we'll also talk about the treatment duration. This is what the FRAX calculator looks like. You can Google it just like I do when I need to use it. And I think it's important to realize, I remind myself that for those patients who have osteopenia, they also can be at increased risk for fracture. And in fact, 50% of fractures occur in those with osteopenia. So it really behooves us to figure out who with osteopenia warrants treatment. And the FRAX calculator gives us a 10-year probability for hip or major osteoporotic fracture. And I will look at the FRAX with the patient and walk through it with them. And again, a major osteoporotic fracture, I think I emphasize to patients, it doesn't mean it's a particularly bad fracture. It means it's a fracture in one of these 4 sites. And the FRAX score provides the level of fracture risk, but it doesn't give us the intervention threshold. And each country has its own intervention threshold. So we've decided to treat this patient with osteopenia who has elevated FRAX scores with a bisphosphonate, and we'll walk through how long to treat. And there are 2, I think, major trials that help us in our consideration of how long to treat. The first looks at how long to treat with alendronate. And the initial trial that brought alendronate to approval was the FIT trial. And then there was a long-term extension. So the FIT trial was a 5-year study of alendronate, and the long-term extension, or FLEX, provided another 5 years. And so the patients who in the first study received alendronate for 5 years versus placebo, they took the patients that had alendronate for 5 years and they gave them alendronate for 5 more years, which was A10, or they gave them placebo for 5 years. So they were alendronate 5, then placebo for 5. And at 10 years, they found that those who had 5 years of alendronate and then 5 years of placebo actually maintained their spine bone mineral density okay. They did have a decline in bone density at all other sites, but this didn't go back to the level of pre-treatment. And in those patients, there was also a gradual increase in the bone turnover markers, but this didn't get back to baseline either. But what they did find was new clinical vertebral fractures were lower in those patients who had 10 years of alendronate versus those who had 5, followed by placebo. And just to be clear, clinical vertebral fractures are those vertebral fractures that are clinically presenting. So they're painful vertebral fractures. And so the risk of clinical vertebral fractures was significantly reduced in those who received 10 years of alendronate. This is just a reminder about the radiographic appearance of vertebral fractures. And I would say that the decision to treat for more than 5 years is a clinical decision that's individualized to the patient. The risk for atypical femoral fractures seems to associate with prolonged treatment. And in some studies, the median duration on alendronate, or on bisphosphonates, I should say, was at 7.2 or 7.3 years. So it's important to really weigh out the potential risks and potential benefits for more prolonged treatment in patients, considering longer than 5 years of alendronate. Well, similarly, zoledronic acid was looked at 3 versus 6 years. And this looked at a similar number of patients, just over 1,200 postmenopausal women. And this looked at 3 years of IV zoledronic acid, which was the initial Horizon trial, which was 3 years of IV Zol versus placebo. And this took the patients that received 3 years of IV Zol and then gave them either an additional 3 more years or gave them 3 years of placebo. And what they found was that the bone density was constant in those people who received 6 years of zoledronic acid. Those that received placebo for the additional 3 years had a slight decrease in bone density, but it didn't go back to baseline. And the bone turnover markers were constantly suppressed in the people who stayed on zoledronic acid and had a slight increase in those who then got placebo after 3 years, but it didn't go back to baseline. And this study looked at morphometric vertebral fractures. And this is an important distinction from clinical vertebral fractures. Morphometric vertebral fractures are those that are found on X-ray that don't, so it's all vertebral fractures, whether it's clinical or asymptomatic vertebral fractures. And the reason that's important is that we know that 2/3 of vertebral fractures are asymptomatic. So many more vertebral fractures occur than present to us with painful symptoms. And so this study found that new morphometric vertebral fractures, so it's actually capturing more vertebral fractures, was lower in those people who got 6 years of zoledronic acid compared to those who had Zol for 3 years, followed by placebo for 3 years. So those at high risk for vertebral fracture may benefit from 6 years of treatment with zoledronic acid. And similarly, the decision to treat with Zol for more than 3 years is a clinical decision that's individualized to the patient. This study was actually done at 9 years, and there was really no difference between the 9 years and the 6 years. So there was no thought of longer than 6 years being warranted for patients. Here's a summary of the durations that we've discussed. For bisphosphonate therapy, we consider 5 years versus 10 years for alendronate, or 3 years versus 6 years for zoledronic acid. And the duration of therapy is individualized to the patient, depending on their risk factors, whether they've had a fragility fracture, when did this fragility fracture occur, such as does it occur during a treatment course or was it before or long before? What's the patient's bone mineral density and T-score, and what are their comorbidities? So just thinking about this, we know that patients who are older are at higher risk of fracture. So these decisions might differ if the patient's 88 versus 68. We know that comorbidities such as aromatase inhibitor use in patients on with breast cancer, or patients who require frequent or high-dose glucocorticoids. And then, as I mentioned, have they ever had a fragility fracture, and when did it occur? And we also know that those with vertebral fractures may get benefit, or those who are at highest risk for vertebral fractures may get benefit from the longer duration of therapy. In considering a drug holiday, there's also not when to start the drug holiday, so after 3 versus 6 or 5 versus 10 years, but how long should the patient be on holiday? And this also depends on the patient's age, their risk factors, their history of fractures, and their other comorbidities. Bone turnover clearly can resume when a patient is on a drug holiday, and so it's important to continue monitoring the patient once the holiday is initiated. And I think this is where I really depend on my primary care colleagues so much, because when a patient is on a drug holiday, I like to be still following them, but sometimes they're not coming back to see me as regularly as their primary care physician. And so the primary care physician can really provide feedback on, hey, I think it's time for you to go back on treatment, or we need to consider this. And also importantly, calcium, vitamin D, and weight-bearing exercise should continue during the drug holiday. The monitoring during a drug holiday, again, relates to the patient's risk factors, their fall risk assessment, maybe they have Parkinson's or at increased risk for falling. DEXA monitoring, considering a role for bone turnover markers, and if the patient has a new fracture during a drug holiday. There really are very little data to guide the duration of the drug holiday, so it really is individualized to the patient. And when we consider therapy resumption after a drug holiday, as I mentioned, the risk for atypical femoral fracture, which is really part of the reason we even consider the drug holiday, declines by 70% in the first year and each year after discontinuation of a bisphosphonate. Sometimes we think about what to do after the drug holiday, and would hormonal therapy or raloxifene be considered, because that would be a different agent, though still antiresorptive, and there are reasons to perhaps not consider that, particularly in older postmenopausal women. I told you, I promised we'll get back to denosumab, and we will. Denosumab has limitations related to risks of discontinuation, and so it may or may not be the right medication to start after a drug holiday, depending on the patient. And the PTH analogs have a 2-year treatment duration. These might be a great medication for a patient who's particularly at high risk for fracture when the patient comes off of a bisphosphonate. This might be a great agent for people particularly at high risk during the drug holiday, or maybe after the drug holiday. And then how long is the next course of antiresorptive treatment? And so the resumption of treatment really is based on established treatment guidelines, but the duration of drug holiday is still quite difficult. And then when you start or resume treatment, how long should treatment last for the next course of treatment? Well, here's a case, and this will help us think through this, I think. This is a 72-year-old woman who's seen in scheduled follow-up. She has osteoporosis and no other health problems, takes calcium and vitamin D. She took alendronate for 5 years and then has had a 2-year drug holiday. And her DEXA scan reveals a significant decline in bone density since being off treatment. She's not had a new fracture, and she wants to know what to do now. Well, we're not really doing polling, and I can't really see what you're thinking, but look at the options and think about, what would you do? you could continue the drug holiday, or you could resume alendronate. You could start one of these other agents. And honestly, any of these are good choices, except continuing the holiday since she's had a significant decline in bone density off treatment. And all of the options that we have are reasonable choices. So in summary, and thinking about how long to treat, we would consider 3 to 5 years or 6 to 10 years of bisphosphonate treatment. The decision for a drug holiday is individualized, and this would depend on finding stable to improve bone density, no fractures, and having 5 years of alendronate or 3 years of zoledronic acid. And how long should the holiday last? Well, the decline in bone density, or hopefully not, but a new fracture. And considering the duration the patient's already been off medication, if they've been off for 4 years and they have osteoporosis, but things are stable, it would still make me a little uncomfortable that I'm not treating them with this much time between treatment courses. What medication to start after a drug holiday? Well, we have lots of the same options. And how long should we treat after resuming? And then again, I would consider 3 to 5 years of treatment again. All right, our last question is, do I need to change my medication since I had a new fracture? Here's a humerus fracture that occurred in a 71-year-old woman. And we know that bisphosphonates reduce fracture risk by 50 to 70%. So it's not 100%. And we won't prevent all fractures in that way. And I would also consider the timing in which the fracture occurred during the treatment course, such as if the fracture occurred, say, 6 months after the treatment was started, then I wouldn't have expected the treatment to be efficacious, and I might not then say that the treatment was ineffective. I would first assess adherence. I think it's important to make sure the patient is taking the medication and taking it correctly. And then in a patient who fractures despite treatment, I would evaluate for secondary causes of bone loss. And here's kind of a guide to the lab testing for secondary causes of bone loss. So the patient comes in with a new humerus fragility fracture. I talk to her about her adherence to the medication. I evaluate for secondary causes of bone loss. And then I consider a change of therapy. If non-adherence is demonstrated and the patient's on an oral agent, then maybe an IV medication would be the right choice. I could consider denosumab, but we're going to get back to that. If adherence is demonstrated, then, and she's been on therapy long enough to think that it's been efficacious, then I might consider a change to a medication with a different mechanism of action, or I may continue the course of therapy because I know that these medications don't reduce fracture rates by 100%. So if adherence is a concern, then denosumab may not be the best option because it has been associated with risks of sudden loss of bone density and multiple spine fractures. It's not appropriate for a drug holiday because with missed doses or stopping it without starting something different, there is the increased risk of rapid bone loss and increased risk of multiple vertebral fractures. And so it's really critical at every visit to reinforce the importance of taking it every 6 months. So in a patient who fractures despite therapy, I would consider modifying the route of administration. I would consider a different mechanism of action for the medication. I'd also consider continuing the same regimen. Just to wrap up, in summary, what we've discussed is the role of calcium and vitamin D as part of therapy, and calcium ideally obtained through diet supplements if needed. I would set expectations with the patient about the planned duration of therapy, weigh out the risks and benefits of the medication, and I also would discuss with the patient if a fracture occurs on therapy, whether a medication change is warranted. I thought I would provide you with a few resources for you and for your patients. There are provider and patient resources on the International Osteoporosis Foundation and Bone Health and Osteoporosis Foundation websites, also on the ACR website. We published a book a few years ago. It's a guide for patients and it's called Facing Osteoporosis. It's available on Amazon and Kindle and has been a useful resource for my patients because there are so many questions that are raised by patients. And I thank you for joining, and I would be happy for you to be in touch with me by email if you have particular questions about particular patients and decisions that you're making. And I would be happy to answer any questions.
Thank you, Dr. Bolster, for that fantastic presentation. I really appreciate it. It looks like we do have a couple questions in the Q&A. So we've got first from Dr. Jeremy Smith, who's one of our primary care fantastic internists. He says, can you talk a bit about how T-scores at that 5-year mark might impact your decision to extend a bisphosphonate treatment? Do you want to go ahead and speak to that? I think you did mention that briefly.
Yeah, it's I think first of all, I would look, so we look at the bone density for comparing DEXA scans more than T-scores to see the significant change. The machines now really often read it for us. And so if the patient has had stable to improved bone density after 5 years, then I consider that to be an adequate course of treatment. And I would stop treatment. But I think the question is important in terms of what is the T-score, and that really will help guide me in terms of how long to treat. I mean, how long to have the drug holiday. So if the patient has a T-score, say of minus 3.2, then I still, depending on where they are in terms of comorbidities and fracture occurrences at the 5-year mark, I might still consider stopping at 5 years, but I would likely have a shorter drug holiday. Exactly. And those patients who have very low T-scores. And in somebody who has had fractures maybe a while ago, has that low T-score, I might even consider a PTH analog during the drug holiday to help mitigate against additional bone loss and actually may build bone.
That's great. We've got another question from the chat, which is from Dr. Tiffany Lynn, who is actually our fellowship director, who's fantastic as well. And she says, when recommendations differ among society guidelines, how do you choose which one to follow? And I think that's a nice question as well.
A little dicey. I think really guidelines, even if we had one set of guidelines, it's a guideline. And so I use it to help make a decision with a patient. And it may give me kind of more angles for talking to the patient, but it ultimately is going to come down to how that patient feels about it. And I might even present to patients that some doctors might do it this way, and other doctors might do it this way. And we need to find the way that works the best for you.
So shared decision making, I love that. No, that's fantastic. Great. Similar to that, you mentioned earlier that when interpreting FRAX scores, there are country-specific thresholds. We've got some learners on the call today too. So just to remind them, hip fracture, 3%, overall fracture risk, 20% as the treatment threshold. Is that what you, okay, perfect. Excellent. That would remind them that as well. I love that. And then here's a nuanced question that I have for you as well. Oh, actually, here, we've got another great question here from one of our nephrologists saying, I'm a nephrologist. Other than PTH, what can I use to differentiate high versus low bone turnover disease?
I think that's been shown. So the bone turnover markers are a little bit fraught with problems, and it hasn't all been worked out. They're not perfect, but the bone turnover markers can be used as another piece in the puzzle. I rarely use them to like clinch a decision, but I use it to help guide me. And the C-telopeptide is a serum test, and the N-telopeptide is a urine test. And actually, C-telopeptide has been shown to be more reliable than N-telopeptide. And many institutions are no longer performing N-telopeptide. So it needs to be a fasting early morning sample because there is biologic variability with the C-telopeptide throughout the day. So I have patients come in to do a fasting C-telopeptide. And then it's also unclear what level is thought to be adequate suppression of bone turnover. But there are articles to support a level less than 280. There's also literature that if it's in the 300s or 400s, it might be okay. I tend to really like to see it be quite suppressed. And I use that to help guide me in terms of resuming therapy. Because if a patient's been on an antiresorptive and a marker of bone turnover is then suppressed because they've been on an antiresorptive, it may stay suppressed and likely will stay suppressed for a while, even a couple years. And so
that's-
once you start seeing it climb up and maybe get over that 280 to 300 range, it can be helpful.
That was incredibly helpful. I've got another great question from the audience. They asked, in those with severe T-scores, like you mentioned, that -3 or others, thoughts about anabolic therapy before a bisphosphonate versus after a bisphosphonate?
Yes, I love that. I think that I'm so glad somebody asked that. I really debated including that as part of the talk. And so there's been thought for years about the anabolic window. And now we have different anabolic agents, and there's really a lot of support for why not build bone first. Build bone with an anabolic, and then all anabolic agents need to be followed by an antiresorptive to help maintain that bone building process. And there's also data to support that patients who take an antiresorptive first may get a blunted effect to the anabolic. So yes, starting with an anabolic is a great option. Thank you.
Wonderful. Well, we are right at 9 a.m. and I just want to thank you for your tremendous presentation today. We had great engagement by our internists, our nephrologists, our rheumatologists, others. So clearly we all gleaned something from this fantastic presentation. Thank you so much, Dr. Bolster.
Thank you so much for having me. Have a great day.
Thank you. Bye-bye.
Bye.